I'm happy to be here today. I'm Debbie Richardson, the Associate Professor and Section Chief of Geo and Oncology at the Stevenson Cancer Center at the University of Oklahoma Health Sciences Center. And today I'll be discussing Oncology Today, Novel Agents and Strategies in Ovarian Cancer. Folate receptor alpha is an excellent target for an antibody-drug conjugate, especially when we're thinking about epithelial ovarian cancer. Folate receptor alpha is a cell surface folate receptor which mediates folate transport into epithelial cells. Its expression is limited on normal cells, but we see it upregulated on several different cancers, including ovarian, endometrial, and triple-negative breast cancer. And it's highly expressed on the surface of high-grade serous epithelial ovarian cancer, and that's kind of nicely portrayed here. You can see on the left is 1+ in intensity, and if you get to the right side of the slide, that's 3+ intensity, quite dark. And we had some preliminary data that made us fairly excited about an antibody-drug conjugate known as mirvetuximab soravtansine. And basically, this is an antibody-drug conjugate that targets folate receptor alpha. So this was the Forward 1 study design. This was a large phase 3 randomized controlled trial. And basically, it randomized patients with platinum-resistant ovarian cancer who were folate receptor alpha positive. And that was defined as medium or high, with median being 50 to 74% of their cells positive at the 10x. And remember this, because we're going to talk about the different types of IHC that can be done for Folate 1, and then high greater than or equal to 75% cell positive at 10x, with a performance status of 0 to 1, and patients could have 1 to 3 prior therapies. Now, there are also a few statistical assumptions I think people should be aware of. One, they use a Hochberg procedure, which essentially controls for multiple comparisons. They did use an alpha set at 0.05, two-sided, and power of 90%, looking for a hazard ratio of 0.58, assuming that the control arm would have a median progression-free survival of 3.5 months. And patients received either mirvetuximab at 6 milligram per kilogram at an adjusted ideal body weight once every 3 weeks, or investigator's choice chemotherapy. And that was either weekly paclitaxel, PLD, or topotecan, either given weekly or day 1 through 5. And the primary endpoint of this trial was progression-free survival by blinded independent review for the both intention to treat population and then the high folate receptor alpha population with multiple secondary endpoints. And this, unfortunately, was the results of our trial. So on the left is the intention to treat population. And as you can see, the hazard ratio is 0.981. You can almost line those curves up. So mirvetuximab is in blue, chemotherapy is in that pink-purple color. The median progression-free survival for mirvetuximab arm was 4.1 months versus 4.4 months. On the right is the folate receptor alpha high. And this gave us some enthusiasm that perhaps mirvetuximab still had a role to treat high-grade serous ovarian cancer. This hazard ratio was better at 0.69 and had a p-value of 0.049. However, as I mentioned before, they used the Hochberg procedure. Therefore, this was not a low enough p-value to be statistically significant. It would have needed to be 0.025. The median progression-free survival, however, was 4.8 months in the mirvetuximab arm compared to 3.3 months in the chemotherapy arm. And basically what we realized going back was that perhaps the 10x scoring method was not the appropriate method to use to really identify who was going to most benefit from mirvetuximab. So more trials were designed. And this is the folate receptor alpha scoring. So on the left is what we had traditionally used to get to the point of Forward 1, which was the PS2 plus scoring. So in all prior studies, PS2 plus scoring was used to assess the folate receptor alpha expression. And eligibility was determined by staining intensity and percentage of tumor cells staining at 0, 1+, 2+, or 3+. And they were considered positive if greater than or equal to 50% of tumor cells with the folate receptor alpha membrane staining was greater than or equal to 2+ intensity. On the right is the 10x scoring that was used in Forward 1, which is a simplified scoring method to assess the folate receptor alpha expression. Basically, eligibility was determined by scoring just the percentage of cells with membrane staining by less than or equal to 10-time magnification without regard to intensity. And what we learned was that this kind of enrolled patients with less folate receptor alpha expression than anticipated on that trial. So that led us to design SORAYA trial, which was the single-arm pivotal trial for mirvetuximab using PS2 plus scoring in folate receptor alpha high platinum-resistant ovarian cancer. Dr. Matulonis presented this data at SGO in 2022. The primary endpoint of this was objective response rate by investigator. Secondary endpoint was duration of response. The plan was to enroll approximately 100 patients. They would have platinum-resistant disease with a primary platinum-free interval of greater than 3 months. Prior bevacizumab was required. This was different than our prior trial. Prior PARP inhibitors were allowed, and patients with BRCA mutations were allowed. And this was the data. So we saw a response rate of about 31.7% and a long duration of response of 6.9 months. There were 104 patients that were eligible to be assessed for the response rate. And we did see a 4.8% complete response, 27% partial response. And you'll notice that on the side effect profile here, not much alopecia, which patients appreciate not losing their hair, not a lot of neuropathy, though some neuropathy, and that was captured by various different terms, as you can see listed, and not a lot of myelosuppression. There can be mild anemia, thrombocytopenia, or neutropenia. So the one thing that we should also be aware of with mirvetuximab is it has some unique side effects. So it can cause some ocular toxicity, mostly keratopathy and blurred vision. And you can see about half of the patients, or 47%, developed mostly low-grade ocular toxicity. There are some ways to prevent this. I'm going to show you some eye care, but by using some artificial tears, by using corticosteroid eye drops, it's very predictable. The median time to onset is typically during cycle 2, about 1.5 months after starting mirvetuximab. Can be managed with dose modifications if they are needed. About 22% of patients in this trial required either a dose delay or reduction, and they tend to be reversible. At the data cutoff for this trial, more than 80% of patients who had grade 2 to 3 events had resolved to grade 0 or 1 at the data cutoff. 9 patients were still receiving mirvetuximab or were being followed up for resolution. Only 1 out of 106 patients enrolled had to discontinue due to grade 4 keratopathy, which did resolve within 15 days. And this led to the FDA giving accelerated approval to mirvetuximab for platinum-resistant high-grade serous ovarian cancer. And this is the eye care. So all patients who are going to get treated with mirvetuximab have to have a baseline eye exam. That can be done by different types of eye providers. It doesn't have to be an ophthalmologist. They undergo visual acuity. They need to have a slit lamp exam, and they need an eye exam every other cycle for the first 8 cycles, and then thereafter as needed. It's recommended that preservative-free lubricating eye drops are used 4 times daily to start 10 minutes after the steroid eye drops. The steroid eye drops are used 6 times a day for day 1 through day 4, and then day 5 through 8, it's 4 times a day. And patients are also recommended to avoid wearing contact lenses. There's the website at the bottom of the slide will take you to good information about eye care and also forms for a patient to take to their eye provider for evaluation. So that then led to MIRASOL, which was the confirmatory phase 3 trial for mirvetuximab. And so the patient population here is very similar to Forward 1. However, it went back to the PS2 staining rather than the 10x that was used in Forward 1. Patients had to have high folate receptor alpha, so more than greater than or equal to 75%. Again, it was high-grade serous histology. Again, primary platinum refractory disease was excluded, so they had to have a primary platinum-free interval of greater than 3 months. They could have 1 to 3 prior lines of therapy. Prior bevacizumab and PARP inhibitor was allowed. Prior bevacizumab was not required like it was in SORAYA. And this was the experimental arm, mirvetuximab 6 milligram per kilogram, again, adjusted ideal body weight every 3 weeks versus, again, same control arm of weekly paclitaxel PLD or topotecan with multiple stratification factors. And the primary endpoint was progression-free survival by investigator with a blind to independent sensitivity analysis. And these were the results. This was the progression-free survival curve on the top. And as you can see, it improved progression-free survival with a median in the mirvetuximab arm of 5.9 months compared to 4.3 months in the chemotherapy arm. The hazard ratio was 0.72, so a 28% reduction in progression in the mirvetuximab arm. This was statistically significant. In addition, there was much higher response rate in the mirvetuximab arm, 36% versus 15%, and this was also statistically significant. And also, we did notice that the blinded independent review was concordant with investigator. And so this is the overall survival. The median overall survival for chemo was 12.75 months. And very exciting, mirvetuximab hit 16.46 months. This was statistically significant with a hazard ratio of 0.67. And this really is the first time we've been able to show targeted therapy having an overall survival benefit in a platinum-resistant ovarian cancer population. And we know that the side effect profile of mirvetuximab is a little bit different than the standard chemotherapies, at least the ones that were used in the standard arm. So as mentioned previously, there's not much neutropenia, anemia, or thrombocytopenia. You can see there is some peripheral neuropathy, a little bit less than Taxol, but certainly more than PLD or topo, very minimal alopecia. GI side effects can definitely occur, especially diarrhea, nausea. We don't see much stomatitis. And then here are the ocular toxicities, and this is where you're seeing high rates, but mostly low grade of blurred vision, keratopathy, and dry eye. And then that brings us to the FORWARD-2 study. So one question was, could we combine antibody-drug conjugate with bevacizumab? So mirvetuximab was combined with bevacizumab in this phase 1b/2 FORWARD-2 study. And patient population allowed both folate receptor alpha low, medium, and high. Platinum status was stratified by a platinum-free interval as less than or equal to 6 months or greater than 6 months, and then whether or not patients had ever had bevacizumab. And as you can see, about 47% were high folate receptor, greater or equal to 75%. These patients were relatively heavily pretreated. More than 50% had had at least 3 prior lines. They also had 59% had had prior bevacizumab, and 27% had had prior PARP inhibitors. And this was the waterfall plot. As you can see, the majority of patients had their tumor lesion decline in size. And in fact, the response rate was a little bit over 40% for this combination. Another trial that's being looked at for mirvetuximab is called PICCOLO. This was a single-arm trial of mirvetuximab in high folate receptor alpha patients who were platinum sensitive. It has completed enrollment. We have not seen this data yet. The primary endpoint is response rate by investigator, and the secondary endpoint is duration of response. 75 patients, so relatively small trial. They had to have had 2 or more prior systemic therapies and at least 2 prior platinum-containing regimens. Prior PARP inhibitor was required if they were BRCA positive, and they had to be deemed by their treating physician as appropriate for single agent therapy. So this may have included some patients who maybe had platinum allergy, but still considered platinum sensitive, for example, or had had multiple lines of platinum in the past. Then that brings us to Gloriosa, which is currently enrolling. This is a phase 3 trial of mirvetuximab plus bevacizumab maintenance in folate receptor alpha high platinum sensitive ovarian cancer. And this is a global trial. And if it's positive, then approval could be as soon as 2026. The primary endpoint is progression-free survival. The secondary endpoint is overall survival by blinded independent central review. Plan is to enroll approximately 440 patients with platinum-sensitive ovarian cancer. They can have had 1 prior systemic therapy. They have to have had prior PARP inhibitor if they're BRCA positive, and they are allowing patients to come on with complete response, partial response, or stable disease. And that's not something that's commonly been done before in maintenance trials that start after the chemo. So the stable disease is kind of exciting. After a platinum-based doublet, and the patients have to receive bevacizumab with their chemotherapy. And we know we have some data, some preliminary data, that there is MIRV-BEV treatment efficacy, and also that in recurrent platinum-sensitive ovarian cancer patients who are full or high, that we've seen just MIRV and BEV has an overall response rate of 69% with a median progression-free survival of 13.3 months. And then there's the 420 study, and this is a single-arm phase 2 trial of mirvetuximab with carboplatin, followed by mirvetuximab continuation in folate receptor alpha low, medium, and high patients with platinum-sensitive ovarian cancer. This is currently enrolling, also a global trial, and depending on when it completes, potential compendia in 2024.
So I was just kind of curious, thinking back on the Forward One study, I guess Monday morning quarterbacking, whatever. But I'm just kind of curious when you look back at the decision, that was a phase 3 trial, right?
Correct.
So when you look back at that decision to do that trial, when you think through it, would you look at it differently now than you all did at that point?
I think if the investigators could go back in time, they definitely would have used the PS2 scoring, and they would have held it to the folate receptor alpha high population, if I had to guess, because that's basically what they did in Mirasol. But I think we learned a lot from it, and I'm really glad that people persevered and didn't give up on mirvetuximab, because when we had used it in earlier trials, it seemed to work. And it was obviously very disappointing to have a negative phase 3 trial, but I'm very, proud of Dr. Moore and the company for continuing to develop the drug.
Yeah, no, that it's such an amazing story. I don't remember hearing anything like that in oncology, let alone gynecologic oncology. To stick to it and go back and kind of redo the whole thing is really an amazing story. But it's always interesting to me when these kinds of things happen. Sort of looking back, whether you would look upon it differently. Do you think that, I don't know how much efficacy data was available at that time, but do you think that maybe there should have been more preliminary work done before they launched the phase 3? I mean, again, it's so easy to look back 5 or 10 years, et cetera, but just curious how you think it through.
I think we had enough preliminary data to show that mirvetuximab looked active. I think what maybe we didn't have enough data about or had validated enough was that 10x scoring. And, it was an expensive, I think, lesson to have done it learn that lesson the hard way in the phase 3 trial, but to go back and do it the right way then with the PS2, more complicated, but, more effective at determining who was going to benefit from therapy.
One other question. Could you comment a little bit on duration of response that's been seen with mirvetuximab in the trials, as well as your own clinical experience?
Yeah, so it was about 6.9 months, and that's fairly long in platinum-resistant ovarian cancer. We obviously talk a lot about progression-free survival, but you can only really do that if you have a control arm. When you have a single agent, single arm, it's best to look at the duration of responses. And that's very meaningful. Many drugs don't meet that long. And in fact, some people think 4 months is sufficient. Other people will talk about that 6-month kind of barrier. And what I know is that the longer you can keep somebody on a treatment that they're tolerating well, their quality of life tends to be maintained and they can continue to enjoy life. And I think that's part of our job, is not just to help extend life, but also to maintain quality of life. And I think mirvetuximab does that really well.
Okay, please continue.
So back to our 420 study, the primary endpoint is going to be response rate by investigator. You can see these secondary endpoints. We're going to enroll 110 patients or so. Again, it's platinum sensitive, 1 prior platinum treatment, and of course, prior PARP is required if BRCA positive. And people may wonder why. Well, part of this is, can we replace paclitaxel, for example, with mirvetuximab? So we know that we use platinum doublets, and they all have potential side effects that are different. Alopecia can be a major problem with paclitaxel. So can peripheral neuropathy with gemcitabine that we sometimes combine with carboplatin. It can be myelosuppressive, especially with thrombocytopenia. And then we have PLD, which also has some side effects. So that's where this comes in to say, can we replace one of the other drugs that we're using with platinum with mirvetuximab and then continue mirvetuximab maintenance? And many of these patients will have had prior PARP and prior BEV, and we don't really know what to use for maintenance in that setting. We do have some preliminary experience with mirvetuximab in the platinum-sensitive population, including in median, now these are small numbers, but in medium-high folate receptor alpha, 80% response rate, 15-month median progression-free survival. In the low, medium, high, so expanding it to the low, 17 patients, response rate drops off a little bit, 71% though is still pretty respectable. And we see even over a 50% response rate mirv alone in low folate receptor if they are platinum sensitive, again, small numbers. So that brings me to some other antibody drug conjugates that are under development for ovarian cancer. And so there are several actually under development, even targeting folate receptor. One of that is luveltamab tazevibulin. And this has a hemiasterlin derivative cytotoxic payload, and it's less susceptible to tumor efflux pumps. Also, a lot of antibody drug conjugates are felt to cause some immunogenic cell death and has bystander effect. And this is a small phase 1 data that they have, and they have 2 different dose levels. So you can see in the lighter blue is the lower dose level, in the dark blue is the higher dose level. And you can see the waterfall plot with quite a bit of reduction in target lesions. And this had pretty decent response rates. We saw for the 5.2 milligram per kilogram, if they're in that medium expressing folate receptor, 43.8% in the 5.2 milligram per kilogram, and the response rate was 31% in the 4.3 milligram per kilogram group. And then if you go to the folate high, then it was 56% response rate and almost 70%. Again, small numbers, so we always have to be a little bit cautious about that, but this is exciting for preliminary data. And the key to know about luveltamab is it can cause neutropenia. That's the most common grade 3 AE, and also the most common reason for dose reduction. And definitely seen more at the higher dose at the 5.2. It can be managed with G-CSF if needed. Arthralgia was the second most common grade 3 and second most common treatment emergent adverse event leading to dose reduction. The other grade 3s that were seen were felt to be unrelated to study drug. This is yet another antibody drug conjugate targeting folate receptor alpha. This is Morab 202. And this combines the monoclonal antibody farletuzumab to eribulin. And there are 2 doses that are being explored, 0.9 milligram per kilogram and 1.2 milligram per kilogram every 3 weeks. And again, this is some preliminary phase 1 data, waterfall plot on the top. So you can see quite a bit of reduction again in target lesions. And for high-grade serous, it was 31%. And then in their second cohort, the high-grade serous had a 50% response rate. And treatment related adverse events. The biggest thing to be aware of this one is pneumonitis. We know many antibody drug conjugates can have some pneumonitis associated with that. There was mostly low-grade bone marrow suppression, and overall this is fairly well tolerated with the exception of noticing the pneumonitis. Now, I will point out most of the pneumonitis is low grade, mostly grade 1. And to remind you, grade 1 pneumonitis essentially means it's picked up on imaging, most commonly a CT of the chest, but the patient's asymptomatic. So no cough, no shortness of breath, no low O2 sats. But it is important to be aware of that. And so dose optimization is currently ongoing in their phase 2 trial, looking at 0.9 milligram per kilogram versus 1.2 milligram per kilogram. And then that brings us to upifitamab rilsodotin, or UpRi. This was a first-in-class antibody-drug conjugate targeting NaPi2b. And the payload is proprietary to the company, but basically it's a DOLA lock, auristatin F HPA. So what happens is that gets taken up into the cell, it's able to diffuse out and cause a bystander effect, but then once it's metabolized, it becomes locked in the cell and it could no longer diffuse to other cells. And NaPi2b is a lineage antigen. It is not an oncogene. It is on the surface of high-grade serous ovarian cancer. About 2/3 of ovarian cancer express it. And there was an assay under development that was using a TPS scoring method, and that's kind of in the lower right panel there. And this was the phase 1b ovarian cancer expansion cohort study design. We presented this data at SGO. So this enrolled patients with platinum-resistant high-grade serous ovary cancer. They could have 1 to 3 prior lines. They could have up to 4 prior lines, regardless of platinum status. And they had to have either archival tumor or fresh biopsy. Nobody with platinum refractory disease, primary platinum refractory disease, was eligible, and patients received UpRi IV every 4 weeks until disease progression or toxicity. originally we opened the trial at 36 milligram per meter squared. That was in August 2019. After the MTD was hit, we increased that dose to 43 milligram per meter squared to a max of about 80 milligrams in December of 2019. And the primary objectives were to evaluate the safety and tolerability of the maximally tolerated dose or the recommended phase 2 dose. And this was some of our data. So you can see the waterfall plot on the top. And again, majority of patients had a decrease in target lesion. And you'll notice that they're in two different colors, orange and purple. Orange is in the dose group 36, purple was the dose group 43. What we found was actually a higher response rate in the lower dose. So the response rate for at the top also of this is NaPi2b high, which was defined as a TPS score of greater than or equal to 75. And then at the bottom is the entire population. So the response rate in the NaPi2b high of all dose levels was 34%. If we look at the dose group 36, it was as high as 44%. However, again, these are small numbers. If we look at the overall population, the response rate was 23%. And on the right, you see our treatment-related adverse events. Again, orange is the lower dose, purple is the higher dose, and the dark shade is the grade 3s. And what we saw that was that the lower dose was less toxic, more tolerable. So the most common side effects seen were fatigue, nausea. We saw some transient AST increases that typically resolved prior to the next dose. We did see some thrombocytopenia. Again, that tended to be limited in time and usually resolved before patients were due for the next dose. We also saw some pyrexia. In addition, there was pneumonitis seen in this trial as well, and it was higher in the 43 milligram per meter squared compared to the 36. And all of the grade 3 and higher happened at that 43 milligram per meter squared dose. So based on that, we decided actually to move forward with a 36 milligram per meter squared dose. That seemed to be dose optimized, where we would maintain efficacy and decrease toxicity. So that led us to UPLIFT, also known as OVARY67 and GOG 3048. This enrolled patients with platinum-resistant ovarian cancer, 1 to 4 prior lines. Patients could go on if they had peripheral neuropathy grade 2 or lower. They either had to have archival or fresh tissue. If they only had 1 to 2 prior lines, they had to have had bevacizumab in the past, and they also could not have primary platinum refractory disease. The primary endpoint was confirmed response rate in the NaPi2b high group, with a plan of at least about 100 of patients that were NaPi2b high. So overall, the plan was to enroll approximately 180 patients. This trial did close to enrollment, and unfortunately, we had a memo saying that it did not meet its primary endpoint. And in fact, the response rate was overall for the NaPi2b high about 15.6%. So that brings me to some other antibody-drug conjugates under development. This is DS6000A.
Could I just ask before you go on, could I just ask a little bit more about the trial? You said the response rate was 15%?
Correct.
And that was the reason the trial was closed?
The trial was closed because it had already met enrollment, but it failed to meet its primary endpoint. And so this was a pivotal trial with a registration in mind. And basically the lower confidence interval was 10%, and it had to exclude, I believe, 13% to be statistically significant. And so the overall response rate we were looking for in that trial was 25%, and 15% was just too low for it to have met its primary endpoint.
So it's not going to be further developed?
Not at this time. The company has kind of made a few statements. So there were a few trials ongoing. So UPLIFT had already met its inclusion, had already met its patient population. But Up Next, which was the maintenance trial looking at UpRi, and also Upgrade, both of those have been halted, and the development of UpRi at this point has been halted by the company. Right now, we're kind of doing a deep dive to try and understand why we found what we found, because it's surprising to us. In fact, I still have a patient on that trial who's been on for 1.5 years at this point. And so we're trying to understand, why did this happen? Can we identify something like, was done for mirvetuximab, for example? Is there something that explains it? And so I wouldn't say that UpRi will never be further developed, but we need a lot more information before we can determine where its future lies. So for now, all the trials have kind of come to a halt.
Okay, please continue.
So that brings us to DS6000A, which is a antibody-drug conjugate that targets cadherin-6 or CDH6. This is the phase 1 first-in-human study in patients with renal cell carcinoma and ovarian cancer. This uses a little bit different payload. It's an exatecan derivative. It has a high DAR of about 8. It is actively enrolling currently, and the estimated enrollment's about 110 participants. It has not quite closed yet. And on the right, you can see the waterfall plot. In pink is the highest dose, 9.6 milligram per kilogram. So the type of cancer that they have is written because this is a combination of different histologies. The majority, though, of patients that had response were platinum-resistant ovarian cancer. And as you can see below, overall fairly well tolerated. There was some neutrophil count decrease that was noticed at the higher doses. There was some anemia. There was a case of febrile neutropenia at the 9.6 milligram per kilogram dose. And there was a platelet count decrease this is grade greater than or equal to 3 in the 9.6 milligram per kilogram dose as well. And then this is just a slide showing kind of various combination approaches that are being evaluated for patients with PROC. These are phase 3 trials. So on the left, we have Rosella, which is relacorilant, which is a selective glucocorticoid receptor modulator, pretty novel for ovarian cancer. That the idea is it may resensitize tumors to taxanes. This is being given in combination with nab-paclitaxel. And the reason why it's being combined with nab-paclitaxel is because you can't give steroids with it. And you have to give steroid premedication if you use paclitaxel or docetaxel. And it's, again, investigator choice chemotherapy, and that includes PLD, weekly paclitaxel, topotecan given of one of two doses, or also nab-paclitaxel is an option here, which is different than some of our other trials that we've talked about. In the middle is phase 3 EPIC-O trial. That's alpelisib with olaparib versus single agent chemotherapy. And alpelisib is a PIK3 kinase inhibitor that may sensitize homologous recombination repair proficient high-grade serous ovarian cancer. Those are hard to treat patients to PARP inhibitor therapy. And they're being randomized to either that combination of alpelisib with olaparib or investigator choice chemo. In this case, they limit it to only 2 choices, weekly paclitaxel or PLD. So no topotecan as an option in this one. On the right is the phase 3 INNOVATE-3 trial, which was looking at tumor treating fields with paclitaxel versus paclitaxel alone. The idea is that tumor treatment fields have maybe some kind of novel ways that they work. They may interrupt mitosis. They also may interfere with cell motility and migration, and there also may be some immunogenicity. Unfortunately, we just got the results that this trial failed to meet its primary endpoint of overall survival, with a median overall survival in the experimental arm of 12.2 months compared to 11.9 months in the weekly paclitaxel arm alone. And these are some cases I put together.
Before we get to the cases, just if I could ask you a couple of questions. One thing, when you first went through the UpRi stuff, I was a little confused, and then I just looked it up because I thought I had read that there were bleeding events, grade 5 bleeding events, and you didn't mention that, but I thought that was the reason it was closed.
So for Uplift, it wasn't closed. Basically, Uplift had already enrolled, and the reason why development is being stopped is because it failed to meet its primary endpoint. However, it was true that prior to that being known, UpNext and UpGrade were both put on a partial clinical hold by the FDA because of bleeding events. And in other words, we couldn't enroll new patients, but they are allowing patients who are actively treating to remain being treated as long as they signed a new consent form.
I'm assuming these patients that bled were not thrombocytopenic as the cause. Is that correct?
Correct.
And any reason to think the drug itself, BTK inhibitors can cause bleeding, but any reason to think the drug itself could cause bleeding?
I think it's possible.
Do you think it's possible it's random chance?
I think that's less likely. I think there's a reason. I think we don't know the reason.
And it may very well be we never will, because if the efficacy is, closing down the whole shop, so to speak, maybe it's not going to be looked into. But I just thought it was interesting that they reported that, because I couldn't figure out why. I never heard an antibody drug conjugate causing bleeding.
It was surprising to us as well. There were 5 grade 5 events. It was less than 1% of all the patients who had ever seen, UpRi. But it was worrisome enough that they made you know, the FDA aware, and the FDA, when they got the information, did put them on a partial clinical hold, our Up Next and Upgrade trials, and Uplift as well. But we had already completed enrollment. But I still have a patient treating, because they didn't mandate that we take patients off as long as we felt they were clinically benefiting, once we had signed new consent forms with the patient and informed them of the new risk. I personally have not had a patient have one of those severe bleeding with UpRi, and I think I'm the person that's treated the most patients in the world with that drug.
The whole issue of how drugs become accessible, FDA approvals, is, a pretty complex one. But, actually, I don't know if you're familiar with the antibody drug conjugate belantamab vedotin that was used in myeloma, and it was actually approved, and then they pulled it off the market because of a negative study, if efficacy-wise. And the day it was approved, we were doing a program where we were doing videos of patients. And I interviewed a patient who'd been on it, who responded and had been on it for 4 years. And I'm just kind of curious, do you have any people that you can look at and go, wow, they really benefited from UpRi?
So I do. I have this patient. She's a 57-year-old with
here.
platinum-resistant ovarian cancer, BRCA wild type, originally diagnosed with stage 3C high-grade serous ovarian cancer in June 2020. She was originally treated at outside hospital, underwent surgery with an exploratory laparotomy, a total abdominal hysterectomy, a bilateral salpingo-oophorectomy, an omentectomy, and a suboptimal tumor reductive surgery. She then received 8 cycles of carboplatin with paclitaxel. She had NGS testing done on her tumor. She was LOH high, or homologous recombination deficient, microsatellite stable, had a low tumor mutation burden, had a PIK3CA amplification, and a TP53 mutation. At the completion of her chemotherapy, she was felt to be in remission, was placed on rucaparib maintenance from January of 2021 until July of 2021, when she had progression. She was considered platinum sensitive at that time and started treatment with carboplatin, PLD, and bevacizumab from August of 2021 till November of 2021 for 4 cycles, when CAT scans showed progression. She then was offered options, both standard of care and clinical trial, and opted to go on Uplift. And so she received UpRi starting in January 2022 and remains on that trial to this day. She's had 18 cycles. She has gotten a partial response. She has been dose reduced for proteinuria. She's tolerating the treatment very well and actually traveling all over. She just got back from an 18-state driving trip with her husband. She's been to multiple different continents while on this drug. She loves that it's dosed every 4 weeks, loves that she has her hair. So it's patients like this that make me feel this drug has some activity. Can we identify potentially who it works well in?
Any thoughts about how you might be able to do that, or any speculations about how to find people like this?
I think we need some data. I'm very curious what happened. Did something happen with the manufacturing of the drug? Are there things that we can find in the PKs? I think there's a lot of unanswered questions here. I feel like we need to do a deep dig, kind of like was done in Forward 1, and try and understand the data.
Interesting. How about your next case?
So that's a 58-year-old with BRCA wild type, diagnosed with stage 3C high-grade serous ovarian cancer. She underwent neoadjuvant carboplatin and paclitaxel in a clinical trial. She was randomized to the standard of care arm, received 3 cycles from July till September 2022. She then underwent an interval tumor reductive surgery to no gross residual October of 2022. She then resumed chemotherapy and completed additional 3 cycles of carboplatin and paclitaxel, completing in December of 2022. Her next generation sequencing showed that she was HRD test negative. She also had a TP53 mutation, an NBN mutation. She was microsatellite stable. She had low tumor mutation burden, and Fuller 1 was 90%. which is considered high. She unfortunately was diagnosed with progression in July of 2023. She was not RECIST measurable at that time. Her progression-free interval is 7 months. She has been started on carboplatin, PLD, and bevacizumab, and the plan is hopefully to put her on the Gloriosa maintenance trial as long as she remains eligible at the completion of her chemotherapy. And that's where she'll get randomized to either bevacizumab maintenance alone or adding mirvetuximab to the bev.
Anything else you want to say about this case?
Unfortunately, in this case, she didn't have a very long progression-free interval, but it is longer than 6 months. I opted not to give the patient maintenance. Well, it was a shared decision-making between the patient and I after her upfront therapy. For one thing, she had been on a clinical trial, and she was not HRD positive. Therefore, technically, no maintenance was recommended on the trial because the trial did have recommended follow-up. We did discuss, though, however, standard of care options, which would have included at that point niraparib would be the only technically labeled thing. The only other option would have been to have given her some extra chemotherapy, adding bevacizumab, and then considering bevacizumab maintenance.
Just out of curiosity, currently, right now, in the primary maintenance setting, what are you doing about patients who are HR proficient?
Typically, I'm offering them either bevacizumab with their chemo and bevacizumab maintenance, a clinical trial if I have one, or niraparib. We talk about it. I have not had a patient who has been HRD test negative or HRP opt for niraparib when we go over the data and the potential side effects of the PARP inhibitor.
Are you ever tempted, or would you ever consider using niraparib plus bev?
So you can do that. There was a trial called Ovarian that was combined niraparib and bevacizumab, because one question was, could you combine those two agents because of the hypertension, side effect that niraparib can have as well as bevacizumab?
Right.
But actually,
Right.
Ovarian showed that you can safely give that as maintenance. It is, I think, an option. It's not FDA approved. I think you have to talk to the patients about pros and cons of the medications, but I think it remains an option. In general, the FDA approved maintenance would be olaparib with bevacizumab in the HRD positive patients. So we'd be off label using niraparib bev.
Right, but you couldn't use olaparib bev, correct?
Only for HRD positive, though.
Right,
So if they're
that's what I mean.
HRP,
HR proficient, you couldn't. Right.
correct, right. So yes, you could consider using niraparib bev in your HRP patient. The question is how much benefit. I think we have limited data to know how much benefit would an HRP patient get from that combination maintenance, and looking at kind of efficacy versus side effects. But we do know that it's safe because there was a maintenance trial of Ario.
Yeah, I'm just curious if you've ever done it. I fantasize maybe a younger patient who wants everything done, et cetera, et cetera. Have you ever actually done it and tried to do it?
I have only on trial. I treat a patient on Ovario, but I have not done it off trial.
All right, let's hear about your next case.
So this is a 45-year-old BRCA wild type, again, recurrent high-grade serous ovarian cancer. She received neoadjuvant carboplatin, paclitaxel, and bevacizumab for 3 cycles at an outside hospital. She then underwent a tumor reductive surgery in September of 2020, followed by 3 additional cycles of chemotherapy, and was considered to be NED at the completion of her chemotherapy. Her next generation sequencing showed her HRD test was negative, folate negative, and she was ERBB2 2+ IHC, which is a little bit interesting. We're starting to think about that for ovary cancer. She got niraparib maintenance. So this is a patient, to your point, that is HRD test negative, but was young, got niraparib maintenance for 9 months. They actually dropped the bev. They did not continue the bevacizumab maintenance with it. So they did switch maintenance. She underwent progression in October of 2021. She was considered platinum sensitive and got carbo PLD for 6 cycles from November of 2021 to April of 2022, when she then had progression. She then received topotecan weekly with bevacizumab for 3 cycles from June 2022 till August 2022, had progression, and then came to our phase 1 unit, and we did a consult and enrolled her on the DS6000 trial. She started that in October of 2022. She's been on it ever since. It's 14 cycles, and she's tolerating quite well, mild nausea, and her best response is a partial response. So that's our antibody-drug conjugate that targets cadherin 6.
Any tolerability issues?
Nope, she's tolerating it very well. I haven't had to dose reduce her. She's hasn't missed starting her cycles, and she has to travel a couple hours to get here actually because she lives on the east side of our state.